Hi, welcome. My name is Valentine, and I'm one of the Admiral nurses that works here at Dementia UK on the helpline and clinics. And today I'm going to talk to you about dementia and diabetes. Worldwide, the prevalences of dementia and diabetes are both increasing, particularly in older people. Rates of diabetes in people with dementia are between 13 and 20%. Diabetes management and diabetic self-care may be adversely affected by the presence of dementia. There is also a need to know what interventions work best in the management of diabetes in people living with dementia and in different care settings and at different stages of the dementia trajectory. So, what are the aims and objectives today? So, I've put today the aim of the session is to provide evidence-based care and support for a person living with both dementia and diabetes and also their family. I think it's important to acknowledge the role of the family. Often, if a person with dementia is diagnosed with diabetes, the management of the condition, the diabetes, falls to the carer. Also, if a person with diabetes develops dementia, although, initially the person may require minimal support from the carer or the family member, eventually more and more responsibility will fall to that member or carer. So what objectives are there? I've put to gain knowledge of diabetes and types, to identify how dementia impacts upon a person, to manage their diabetes, particularly independently, and also to consider some of the areas of risk and the strategies to reduce that risk for a person with dementia and diabetes, and how you may respond in those situations. Alongside this as well, I think it's important to recognise some of that impact upon family carers. In order to make it more relevant and relate this to clinical practice, I'm going to use a case study linked throughout the presentation. So if we start with the case study. So Damien is 66 years of age. He's got diabetes type 1, and we'll look at different types of dementia in a minute. And he was diagnosed when he was 14 years of age. Damien used to be a long distance lorry driver, but last year had to stop driving because of the changes in his cognition. Damien has now recently been diagnosed with mixed Alzheimer's and vascular dementia by the memory services. Memory services have said that his dementia for Damien is particularly in the middle stages of dementia. So he's had the diagnosis, although not officially, for a little while. And the memory services have already raised concerns about Damien's ability to manage his medication independently, but also some support about daily living activities. So that could be things like personal care, managing meals, as well as managing his medication. So Damien lives with his partner Naomi. Naomi actually is working 6 days a week in a local supermarket. Naomi is his second partner, and Naomi has a son who lives locally, and he's from a previous relationship. So that's the case study that we will keep referring back to during this presentation. So what is diabetes? So diabetes is a condition that causes a person's blood sugar level to be too high, and it affects how our body uses glucose from the food we eat and drink due to insufficient insulin. It is a scientific name, diabetes mellitus, and when we eat food, it is digested and the food enters our bloodstream. Insulin will move glucose out of the blood and into our cells, where it's broken down, and that's where we get our energy from. In diabetes, there is either not enough insulin to move that glucose sugar, or the insulin you have does not work properly, so your body cannot break down the sugar, the glucose, into energy. Normally, for what are the common signs of diabetes? Quite often we hear about the 4 T's. So that would be the first T being toilet. You notice that somebody is peeing a lot, particularly at night time. People feel very thirsty and also very tired. And certainly in diabetes type 1, you notice that people are a lot thinner, they've lost weight, certainly muscle loss. Weight loss, though, is less common in type 2 diabetes. I think you could say as well there's a fifth T, because a lot of people will develop frequent episodes of oral thrush. Some people will develop blurred visions, and also people notice that cuts, the sores take longer to heal as well. So what are the types of diabetes? So type 1 is a lifelong condition, and that's where the body's immune system attacks and destroys the cells that produce insulin. Type 2 is where the body does not produce enough insulin, or the body's cells do not react to that insulin in the right way. Some people can manage type 2 diabetes through changes in lifestyle. So, for example, losing weight, exercising more. But some people will require medication to help manage their type 2 diabetes. Gestational diabetes, that occurs during pregnancy, usually the second or the third trimester of pregnancy. Now, type 3C diabetes, quite rare, but it's where the pancreas is damaged and stops producing sufficient insulin. So things that could cause that could be, say, cancer of the pancreas, pancreatitis, an infection or inflammation, or conditions where the pancreas is affected, such as cystic fibrosis. More and more we're hearing about another type of diabetes, and that's called type 3 diabetes. Now, this is a term that's being used at the moment to link between Alzheimer's disease and certain features of type 1 and type 2 diabetes. This is based upon the theory that in Alzheimer's disease, nerve cells in the brain may become more resistant to the effects of the insulin, and that leads to a buildup of abnormal proteins. What I will say, though, is there's a lot more research that needs to be done to actually understand that link between diabetes and Alzheimer's disease. There are some rare syndromes as well that can cause diabetes, and also diabetes caused by medication, probably the most common being steroid-induced diabetes. I've just done another diagram here just to show you how insulin and glucose is used in the body. So if you've got a very high blood glucose, high blood sugar, the pancreas will then release insulin, and that causes the fat cells to take that sugar, that glucose up from the blood, and that will mean that your blood glucose then comes down. The other way round, if your blood glucose is low, your pancreas will then release glucagon, which causes your liver to release glucose into your blood. And that means then that your blood glucose will come down to a normal level. So that's how your blood glucose is maintained within your body. So what about some statistics? So 1 in 14 people over the age of 65 and 1 in 5 over the age of 80 have dementia in the UK. If we look at diabetes in the UK, we're looking at 5 million people, which is huge numbers. And 90% will have type 2, which basically we should be able to reduce those figures through lifestyle. And 8% is only type 1, and 2% are the rare forms. It's estimated that 81% of people with Alzheimer's will have type 2 diabetes. So what you can see from this already is that if you reduce the number of people with type 2 diabetes, you are going to reduce the number of people with dementia in the UK. So, and when we look at that, does diabetes cause dementia? So research shows that type 2 diabetes does increase your risk of developing dementia, in particular vascular dementia. So having diabetes damages your large arteries, but also your small blood vessels in the brain. And obviously that links then to vascular dementia. Type 2 diabetes can cause your brain cells to not respond to the hormone insulin, and that's where we can sometimes hear the term insulin resistance. And that is where our brain uses energy differently. People with type 1 diabetes who experience what we call high blood sugars and low blood sugars, and they swing between the two, will also have an increased risk of dementia. And also that risk of dementia increases the longer that you've had a diagnosis of diabetes. Well, I will say having diabetes doesn't automatically mean you are going to get dementia, but obviously poorly managed diabetes will massively increase your risk of getting dementia. So I mentioned a term there, insulin resistance. And that's where the research currently is looking at. So basically, insulin resistance means that your brain is being starved, and the brain cells then will eventually die once they're starving. So obviously, the more brain cells that die, then obviously you've got a more picture of Alzheimer's disease where the brain shrinks. Because the body thinks that the brain is low of glucose, it produces more and more insulin. And this leads to a buildup of what we see in Alzheimer's patients when we look at brain scans is these fibrous tissue plaques, and they're called amyloid plaques. Some people say that this increasing need for glucose is why people with dementia often have a craving for sweet foods. And we quite often hear that a person with dementia, their tastes change and they're just wanting their puddings. There are some clinical trials, research at the minute, where insulin is being delivered to people nasally via mist, and the results are showing positive signs of slowing down changes to people's cognition, memory. And other trials are going on where people are given diabetes medication, particularly metformin, and we're trying to see if that reduces the risk of dementia as well. And I've just, because I think you'll be getting a handout, I've just put you a slide there which shows that a kind of like simplified view of that explanation there. Some people, I certainly prefer a picture. It makes me, I can understand it a little bit easier. So if we go back to the case study, and so Damien manages his diabetes. Remember, he's type 1. He manages it by injections of both long-acting and short-acting insulin. So some insulins will last 12 hours, some will only last sort of like 2-3 hours. Damien does his insulin injections and the dosage of that insulin based upon his blood sugar readings, and he gets that via what we call a flash glucose monitor. The one that he uses is Freestyle Libre, and we'll talk a little bit about flash glucose monitors a bit later on in the presentation. So at the moment, Damien's blood sugars are now becoming a bit erratic, and his recent HbA1c was high, indicating poor control of his diabetes. Now, an HbA1c, that is a blood test that is undertaken to ascertain how somebody's managing their diabetes over the last 2 to 3 months. A normal level would be 42. Diabetes control, we would want about 42 to 50. Above 75 massively increases our risk of complications. Over the last 6 months, Damien spends most of his days watching TV or sleeping on the sofa. And again, that kind of apathy can sometimes come with a dementia diagnosis. So when we look at diabetes treatment, so the focus of diabetes treatment is all around self-management strategies, and that's going to be things like healthy eating, managing our meals, matching it to carbohydrates, our insulin, interpreting what is nutrition labels and what is the nutritional content of foods, could be engaging in physical activities, monitoring our blood sugars, making sure our weight it maintains at within that normal levels, we don't become obese. Again, it's about our medication regimes, which can be quite complex when you're looking at matching your insulin to the not only your food, but also your exercise, your energy expenditure. And that's where there is a need for problem solving, you know. So if your blood sugars are high, what do you do? And to do that as well, you need quite good coping strategies to minimize that risk. So again, things like healthy living, your alcohol intake, what to do if you're poorly, all of those sort of things to help minimize some of those risks that you can get with a diabetes diagnosis. So how would dementia affect that? So if we look at dementia, so obviously the umbrella term used to describe, a set of symptoms that can lead to changes. So if we think about, we've got self-management strategies, and then suddenly somebody's going to have alterations in their memory, their reasoning abilities, their attention span, maybe their judgment about what is risk, what is not risk, as well as their ability to express themselves verbally as well. So all of those self-management tasks, such as your glucose monitoring, your problem solving with what medication to take, managing your medication, as well as the other, everyday kind of activities that you do, such as making meals, going to your appointments, looking at your skincare around your insulin injections, and also about recognizing the need for exercise and keeping your weight in check as well. So all of those things. I mean, if we just take, for instance, the medication, things like doing your blood glucose monitoring, you need to remember to wash your hands. If you don't, it can affect your blood test. If you can't recall how to take your blood test, how to store your insulin, to manage to recognize what sort of like insulin you should be taking, because quite often people will have two different types of insulin. Even what to do if you've got diarrhea or sickness, or have you actually taken your medicine. All of those sort of things will actually impact upon your ability to self-manage your diabetes when you have dementia. If we take, for instance, the medication, and I've just put some tips here for taking medication. Insulin, medication regimes and targeted blood sugar levels. Is there going to be a need to actually reduce some of those targets, simplify the medication? Do we need some more medication prompts, pill organizers, verbal alerts? Do we actually now need to consider, do we need a care package? Do we need somebody to support that person with their technology, to support them with their taking their blood sugars, to actually inject their insulin? And also, do we need to consider some of the medications and the changes, because some will actually increase that confusion. For some people, certainly later on in their dementia trajectory, may also have swallow problems as well. So they may need their medication in a different form. So again, they may need it going into a dissolvable form, or even into a syrup. So what is the technology? So certainly, there are several types of technology now that can help a person manage their diabetes and to prolong their independence for a little bit longer, which is what we would want to do with a dementia diagnosis. We would want to try and support that person to be as independent as possible. So one of the easiest things to do is to change their insulin to once a day, and maybe then probably include medication. Insulin pens are quite easy alternative to syringes. You can get a cartridge that the person's dose can be preset to, so you know that they're going to get that correct dose. You can also get smart insulin pens, so you can see if that person's taken their dose at the right time. And again, that can be used particularly if you're concerned that somebody may be forgetting that they've had their insulin and redoing that injection. Again, you can get apps now on a person's phone. And so if you think about somebody like Naomi, that app can be on her phone as well. And then she can see if Damien is actually taking his medication at the right time. And again, things like the flash glucose monitors, certainly, these are sensors, you usually see them at the back of the arm. And then obviously the smartphone, you just put it alongside it, and it will actually record that person's blood sugar. They can also be set up as well so that they can alert you if your blood sugar is very low. So again, very useful to help support somebody to be more independent with their diabetes. So we go back to the case study then. So what's going on with Damien? So Naomi was finding that Damien's blood sugars were constantly high. He was requiring more and more insulin to keep his blood sugars at agreed targets. On the days that Naomi didn't go to work or when she took holiday, she noticed that his blood sugars were a lot better. Damien wasn't really managing his diet now. His weight was spiraling up as he was eating more carbohydrates and more sugary snacks. Naomi was also aware that Damien was not drinking much fluid while she was out. So again, his fluid intake was very poor. So, how does dementia affect somebody's changes in diet? So, it often affects the appetite, but also their ability to feel thirst, feel hungry, to know when to recall when they've had a last meal, when they've had a last drink. It can affect our changes in taste, and we certainly see that move towards sweeter tasting and that craving for sweeter foods. As the dementia progresses, our ability to actually recognize certain foods, to interpret food labels, and also to verbalize when we're hungry or when we want to drink. Again, as the dementia advances, we may need support preparing food, support preparing drinks, but also handling cutlery and eating independently. And then later on, in the more advanced stages of dementia, we're probably going to have difficulties chewing or swallowing, and may need our food in a different texture, such as puree or soft, moist diet. Okay, so hydration. We know that there's a real issue with people with dementia and not feeling thirst and drinking enough. Somebody with dementia can quickly become dehydrated, which again increases their confusion, but also their ability to develop urinary tract infections, which again will then lead to a higher blood sugar as well. And again, we see then if the person may need help to ensure they drink, the person can also become excessively thirsty. And if that does happen, you need to check if their blood sugars are very high. And again, it could indicate that they've got an infection. So how would we support Damien and Naomi with their managing the diabetes and the dementia as well? So again, if somebody has had diabetes for a long time, they may get quite distressed, may get angry if they're prevented from doing their familiar tasks, like taking their insulin or following their regular diabetes management routine, or if you change it. So again, it is important to look at that personalized plan, find out what they've always done, find out what suits them best, so that at least then you can try and match that into your routine. I've put here the need to avoid hypoglycemia. So we will talk about hypoglycemia in a minute, and that is where somebody's blood sugars drops very, very low. And that, if we need to avoid that, we might need to simplify that medication regime, particularly if there is a risk of somebody overdosing on their insulin or their diabetes medication, or more commonly that somebody is at risk of missing meals. And again, that's where you start to think about technology and aids. And so Naomi then will start, she'll have the app on her phone, so she can actually, even when she's at work, she can still support Damien with regards to what his insulin dose is, or if he needs to eat, or if he needs to take another injection of insulin. Care needs assessment, and that may well be because actually Damien may start to need that he needs support around his personal care, support around meals, or it may be that they need support, Naomi for instance, support around some respite. As we've already seen, Damien is starting to mainly sleep on the sofa during the day, and again he may well now need support around social stimulation, cognitive stimulation, and that's where you can start to look at day centres as an opportunity for Damien to get that stimulation. Naomi, diabetes is new to her. Damien's had that for a very long time. So up until now, Damien has been independent with his diabetes management. So Naomi is having to learn not only about dementia, but she's also having to learn about diabetes. So that's a massive impact upon her workload, but also regarding their relationship as a couple, and those roles and responsibilities are changing within that relationship. So Naomi comes home to find Damien unresponsive on the sofa. She calls 999 and the paramedics have come out. This is the third time she's found Damien like this in a month, and I had to call the paramedics. This time Damien's blood sugar was very low, and despite a glucose infusion being administered via the paramedics, Damien was taken into hospital. So, what is a hypoglycemic attack? Hypo. So, it's an episode of low blood sugar, and it could be dangerous and even life-threatening. It may occur if the person takes too much diabetic medication, misses meals, drinks too much alcohol, or intensely exercises. It's difficult to tell if a person with dementia is experiencing a hypo, because initially people will be irritable, show signs of anxiety, maybe find it difficult concentrating, can become more confused, or their behaviour is erratic or irrational. This can happen with dementia due to other reasons, but again, it could be an hypo. The more physical signs I've listed there, which will include a fast heart rate, pale, sweating, trembling, and in a severe hypo, if the low blood sugar is not reversed, somebody can become unresponsive and lose consciousness, such as what's happened with Damien. So how do you treat it? I'm not going to run through that. You will all have your own policies regarding what to do if somebody has a hypo, a very low blood sugar. In a severe hypoglycemia, where somebody is unresponsive and unconscious, you would put that person into a recovery position. You would probably give them a glucagon injection. You may have those within your work area, or a person with diabetes may actually have that for the carer to use. If there is no glucagon injection, or if the person doesn't recover after 10 minutes of receiving a glucagon injection, then it would be an ambulance. So dementia and sundowning and hypos. So you may have already come across the term sundowning. It's a term used for changes in behaviour that can occur in the evening for people with dementia, usually around dusk. Some people will have these experiences during the day, but majority of people it is around that dusk period. And it's where the person gets a growing sense of agitation, anxiety, increased confusion at this time. It is important though, for somebody with dementia and diabetes, that you check that these changes are not just the person having a sundowning episode. It could also be indicative that they're having, as we've just looked at, some of those signs of having a low blood sugar. It's very subtle differences. So it's really important that the carer gets to know what these subtle changes are in the person, and not just to assume that they're sundowning, but actually perhaps we ought to check their blood sugar and just make sure that they're not low and they're moving towards a hypoglycemic episode. I just want to mention a bit about dementia, diabetes and hospital. And that's really because, that for somebody with dementia and diabetes, we do see higher rates of admissions to hospital, and also the need for post-acute care use. We see longer lengths of stay of hospital admission for the sake. So if you say somebody with a urine infection, admission to hospital, their length of time in hospital is going to be a lot less than somebody with dementia and diabetes and a urinary tract infection. And we see poor outcomes, and that is quite sad, because quite often then we'll see that person moving to a care home from that hospital admission. So it's really important to try and avoid admissions to hospital for people with dementia and diabetes. We also see a decrease in outpatient and GP appointments. That's going to be because the person with dementia and diabetes is not always going to recognise the need for that kind of diabetic management as an outpatient, but also will just not recall when their appointments are and so don't attend. So, what do we do? How do we help people? You know, for people with dementia, hospital is extremely confusing place. It's noisy, it causes distress. So, try and ask for a quiet room. Make sure everyone is aware that the person is a diabetic. So, from Diabetes UK, you can actually get wristbands that say that you're diabetic. So, hopefully, that will communicate even if the person with dementia and diabetes cannot do them themselves. Make sure that any equipment that they use goes with them. We always encourage people to complete either the Dementia UK life story template, and that can be downloaded from our website, or some people will complete the Alzheimer's Society This Is Me. But what it does it gives a really good communication to the ward staff about what is that person's normal routines, the kind of language, what their favourite sort of like, what do they drink, what do they eat, you know, what is the way to comfort that person if they're distressed, what works well. And there is also a need to ensure that things like respect form, advanced care plans, treatment escalation plans are completed and that they go with the person to hospital as well. I would also ask whilst they're in hospital as well to get them reviewed by the diabetic team, because I think that's quite useful, because again, it may be that there is a need to look at a more simplified regime or changes as a result of the hypo or reason for the admission to hospital. So Damien's been attending a day centre now. He goes there 3 times a week, and that enables Naomi to carry on and do some work, but also for Damien to get that much needed routine to a day, social stimulation, and also some cognitive stimulation through the activities that they do within the day centre. Now, the day centre staff have recognised that Damien's very confused today, he's quite agitated, so they've asked Naomi to come and collect him. When he does come home, you know, Damien's talking about packing his things, he's got to go to work, he's got to be driving up to Scotland. So what would you do if you were Naomi? So I would say that this is quite a sudden acute change for Damien. So my first thoughts would be, does he have an infection? Is Damien constipated? Is he in pain? I think my first protocol would be, let's check our blood sugars, because the chances are his blood sugars are likely to be high. I would be concerned about a delirium. So people with diabetes, they have a weakened immune system, and that impairs their ability really to fight off infections. There is an increased risk of sepsis for somebody with diabetes, and we see that in hospital. Having an infection itself increases somebody's blood sugar when they've got diabetes, as also stress. So if you think about hospital, it's very distressing for people with dementia. Again, that just because of that stress, it can actually raise that blood sugar to quite a dangerous level. When we fight infection, our own body's response is to release blood sugar, that fight-flight response. So again, that increases our blood sugar. If you're type 1 diabetes, you also test for ketones. So some of you might have heard about diabetic ketoacidosis, and that is life-threatening. So admission to hospital is essential at that point. We do talk about delirium. For people with dementia, there is an increased risk of developing delirium, which is an acute confusional state, and that can be resolved within 48 hours, but it can take weeks and weeks to actually get back to our original baseline from that intense confusion and disorientation that people can develop with a delirium, particularly as a result of an infection. So how do we stay healthy when we've got diabetes? So it's important, you know, to minimize those risks. We normally have an annual review for both diabetes and also dementia. For people with diabetes and dementia, quite often we will see the diabetic nurse at the surgery more frequently. people with diabetes do get something which is called diabetic retinopathy, and that can affect somebody's eyesight. If it's picked up early through high screening, it can actually prevent sight loss. So that's like really important. So when somebody gets that letter to say they need to go for their eye screening, it's really important that they go, because certainly having your eyesight, I think, is something that's extremely important to everybody. And for somebody with dementia, where you're already got some cognitive changes, you're reliant on your other senses a lot more. Foot problems, and we know that diabetes foot problems are serious but very common as well. So again, nerve damage can affect the feeling in your feet, but it can also affect your circulation. It means that sores take longer to heal, and that's important. Why, you know, when we look at diabetes, we don't cut their nails. They're done by a chiropodist, and it's really important that you dry somebody's feet carefully. You check the feet for sores. You make sure that the skin is quite healthy, and if there are any changes to a person with diabetes feet, you must tell the community nurses or the GP. As the diabetes progresses and the dementia progresses, you may find that you need to change that diabetes medication as well. Even as the diabetes progresses, changes in the kidneys may mean that the ability to use the medication slows down. So again, there may be a need to reduce the medication to minimize the risk of somebody developing very low blood sugars, particularly as we approach somebody's end of life. So what are the takeaways from this session today? So I think one of the important things is we need good diabetic control to reduce our dementia risk. Swings between high and low blood sugars massively increase our risk for dementia when we have diabetes. We need to as well think about early identification of cognition changes for people with diabetes. So one would say, you know, I would argue that when we do an annual review for diabetes, should we not do a cognition test as well? Because the sooner we pick it up, the better. It's important of regular reviews and readjusting the diabetes management, because we need to massively reduce that risk of somebody having low blood sugars and being admitted to hospital, because we know those poorer outcomes will result in that. So there is a real importance to constantly review changing regimes to reduce that risk of complications within diabetes. I've also just, as a last slide, just put some resources that you can link into for some other sources of info. Okay, thank you for listening.